Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of the show. Today, bringing you another really fascinating guest involved in creating a better tomorrow for many people out there. Today, we have the honor of being joined by Angela Aina, who is the co-founder and executive director of the Black Mamas Matter Alliance, where she works to convene Black maternal health professionals and community-based organizations to ultimately develop training programs, various quality improvement initiatives, as well as research projects and Black feminist advocacy strategies to ultimately advance holistic maternity service provision, policy, and system change in global public health. She has over 16 years of public health experience working in different capacities on projects focusing on things like incorporating health equity strategies into both reproductive and maternal health initiatives, strengthening strategic planning and community-based workforce development, as well as data collection. Previously, Ms. Aina served as a public health analyst, a health communication specialist, and a public health prevention service fellow at the United States CDC, working on a range of issues, including Zika and Pregnancy, the 2014 Ebola response staffing, as well as various aspects of scientific program management. She holds a master's in public health degree in international and women's health from Morehouse School of Medicine. She did her bachelor's degree from Georgia State University in psychology and African American studies. And she is found in many popular media outlets, including the Huffington Post, the Atlantic, the Root. And in March 2020, she was recognized as WebMD Health Hero, as well as highlighted as a very important advocate for Black maternal health in Time Magazine. We're honored to have with us today a lot of really cool and important topics to get into. Angela Aina, welcome to our show.
Thank you. Thank you for having me. Glad to be here.
Yeah, it's awesome having you. I'm really looking forward to this episode and a lot of what we're going to be discussing. Would love to start out by handing things over to you a little bit, and hoping that we could maybe start out back in your time at Morehouse. You did your master's. It was entitled "Reproductive Health Knowledge, Attitudes, Beliefs, and Health-Seeking Behaviors of Nigerian-born Immigrant Women in Metropolitan Atlanta, Georgia," which is a fascinating piece of work where, I was going through this. A lot of these themes we're going to be getting into today, but, you start out looking at things like reproductive tract infections and STIs and sort of this cultural ethnic issue in Nigeria where, women are expected to have children. And if you don't, it's their problem. And that's what we concern about. And then you focus on the Nigerian immigrant population here in the United States and do a lot of study in terms of these various topics and comparisons. Take us back to Morehouse and a little bit of, what got you first focused on this space.
Yeah, well, thank you for that thorough background. Yes. Well, at the time when I was in grad school at Morehouse School of Medicine, I had actually been working for quite some time in public health, mostly at the community-based level, working with actually African immigrant serving community-based organizations. Um, and yeah, and also working with other organizations here in Atlanta, Georgia, that were already servicing low-income women across a number of social support issues. And so in grad school, I really, really wanted to just do a deeper dive in specifically maternal and reproductive health, but its intersection with social cultural issues. And then, when you're in public health, when you're doing like a thesis type of research, you really do have to focus. And so I wanted to really narrow my focus on the Nigerian immigrant population here, in particular in the US. And also because both my parents are also Nigerians, and so I'm a firstborn American. And it was just a topic that I was deeply interested in and wanted to explore and be able to highlight that there's a lot more to people and their health outcomes beyond statistics and beyond what we see in epidemiological data. And a lot of
Hmm.
times, what drives people's behaviors, their health-seeking behaviors, most especially, and then just their understanding of what's impacting them from uh, specifically from health issues that people don't like to talk about, especially
Hmm.
in this area of reproductive health and thinking about fertility and whether or not folks have a full understanding of sexually transmitted infections and even what that means in the case of being married, right? I really wanted to bring that out with the work that I had did in grad school, and I actually did it as a mixed method approach, meaning
Hmm.
that not only did I collect just data from people filling out the survey, where they were filling out questions related honestly to their knowledge of the issues, what kind of health-seeking behaviors did they engage in, but then also, I did focus groups with a number of Nigerian immigrant women across Georgia, just to get a little bit deeper into the why and how of some of the questions that I was asking. And so, again, wanting to highlight that beyond these quote unquote typical health disparities data that we hear about African immigrants, and in particular African immigrant women around their sexual and reproductive health seeking behaviors, really wanting to embed that in their social cultural beliefs and what they're actually experiencing so that it tells a bigger story around how we can be more supportive from a public health perspective for this population. So, yeah.
Excellent. Excellent. Yeah, it was a fascinating piece of work. And again, I noticed a lot of the themes that we're going to be getting into in a little bit. So it was pretty impressive from that front too. So I appreciate that overview. You move on, after that work to CDC, and again, multiple roles there. And as I mentioned, a little bit about Zika and Ebola in the intro, but you also are quite active, sort of this intersection of public health, health education, topics including HIV, STDs, even tuberculosis prevention. Say again a couple words about your time at CDC, because I know this will then roll into ultimately what we're going to be getting into in terms of the Maternal Mortality Act, Preventing Maternal Deaths Acts, and so forth. But say a few words about your time at CDC, because it seems like a lot of different topics arrived at your desk, a lot of responsibilities. What was that era like for you?
Yeah, so in all honesty, this is you're really having me to dig into kind of my matriculation as an early career public health professional. Um, I had the fortunate opportunity to actually enter the Centers for Disease Control and Prevention, CDC, through a fellowship pathway
Hmm.
that actually allowed me not only to spend a few rotations at different what we when speaking of CDC, CDC is a huge agency that has multiple centers, institutes, and offices. And so for my fellowship, it was a 3-year fellowship at the time.
Hmm.
And part of it was it was built in a way that you had to spend 1 year at CDC and you rotate at least two different what we call CIOs. And so I had the opportunity to, in my first 6 months, work in the public health law program there. And then the last 6 months, I worked in the injury center, but specifically in violence prevention. Um, and um, and then it was really later on that I also got the opportunity, once I went to my field placement and then came back to CDC, that I was able to engage in the Ebola response and the Zika and pregnancy emergency response. But to back up, um, I actually spent 2 years of my field placement while I was at CDC in North Carolina, and specifically at the UNC Center for Maternal and Infant
Okay.
Health. And along with working at the North Carolina State Public Health Department, specifically the Women's Health Branch.
Okay.
During that time is when I got the real hands-on opportunity to really see maternal and infant health from a teaching hospital perspective, where where they service high-risk pregnancies.
Okay.
And I got the opportunity to see how maternal and infant health is operationalized from a public health perspective at the state level, seeing how the state supports local health departments, academic universities, and community-based organizations, genuinely across that full spectrum of everything from preconception health, prenatal care, how all of these systems engage with hospital systems, clinics, and engage in a number of health education, health promotion activities. And what I took away the most from that experience was really understanding the significant role of the workforce.
Mm.
And and I wanted to just pause there for a minute, because a lot of times the way in which we are, and when I say we, I'm talking about not just public health professionals, nurses, medical professionals, the way that we are taught or trained a lot of times is really from the perspective of, I'm the person that is trained, and so therefore I need to provide education and services to patients, right? And it's like this dyad almost exchange of I have the knowledge, me that has all the degrees, and you that's the patient. I need to tell you all the things, right? And I had the I had the opportunity to just see, and God bless them, to see folks who really believe in the work that they do. They really believe that what they're doing is bringing about change,
Mm.
and folks who are passionate about a desire to address health inequities that literally at that level, especially at the hospital-based and state public health level, you can see it. You can see it very visibly. And so seeing folks that are passionate but ultimately are burned out.
Got it.
They're burned out. They, and knowing how our um, economic systems are, public health, like education, unfortunately, is not as well funded. So folks have to navigate that while also trying to, even at that time, which was, I would say the 2012, 2013. I mean, this notion of misinformation was still a
Right.
thing, especially when you're talking about a huge rise in the significant reliance on folks getting their information on social media, because
Mm.
that was really, really big.
Okay.
And so trying to combat all of that, and also just do the best that you can and do your job and have a passion behind it, just being able to see the ways in which folks made greatness out of nothing
Hmm.
was something that honestly really touched me the most and was something that just made my mind think a little bit differently, or just tilted my vantage point, I will say, in this work significantly during my time at in North Carolina. And so when I had the opportunity, once I finished my fellowship, my field placement portion of my fellowship, and I had the opportunity to come back to CDC, it was interesting that I got opportunities that, while it did pull me away from my passion of maternal, repro, and infant health, still though, I still got more opportunities to, again, work with our workforce, our public health professionals, and really understanding how our systems are set up either to support or not support us
Yeah.
in the work. And got the opportunity to do that with the Ebola response, which was very eye-opening. To be able to see the intersection of, honestly, like, because at that time we had a significant amount of military personnel that came into our emergency operations center at CDC, and then again some of our health professionals. And so seeing that interaction, being able to having to quickly respond to needs of staffing, a lot of the emergency response initiatives that were happening at the different satellite areas that were responding to Ebola in real time on the continent, well, most specifically in West Africa. And then from there, about a year later, doing another rotation at CDC where we had to respond to another emergency response, which was Zika,
Yep.
and then specifically working with the Zika and Pregnancy team, and then really understanding how, yeah, just the folks who work in birth defects, emergency response, and reproductive health, how all of them had to come together and interact and work together, and the ways in which we had to figure out process and systems, um, and be sure that all of our health professionals, our clinicians were well equipped to then deploy, to whether they're deploying to Brazil or Puerto Rico at the time, because those were some of the hotspot places at the time.
Mhm.
Um, to engage with professionals at that level. Just saying all that to say it was just very interesting.
Yeah.
So yeah, workforce has just been a consistent thread in my professional matriculation. Yeah.
Yeah, and again, I'm enjoying your story and listening, and I guess I wanted to do the full sort of Angela Ina arc here to show where you've been to, where we're headed now in the discussion. But it's really fascinating to, again, all these experiences coming together, especially the North Carolina part of the story. And you just mentioned hotspots, so I'll make the segue here because we normally think of the hotspots and Ebola and some of these zoonotic diseases as somewhere else. But as you know, we did an episode with Teo Aragbagbo from Merck's Merck for Mothers division, sort of their social health unit a couple years ago, and he was the one that first sort of introduced us to this United States hotspot. Well, we were talking about India and Bangladesh and Nigeria and Kenya and so on, and he's like, "Hey, we got a major problem here in terms of maternal mortality that no one talks about. In that, this horrible fact that, unfortunately, there's a larger chance of you dying today in childbirth than your mother a generation ago. We have major racial inequities, Black, Native American women, much higher rate. And we have a lot of these what perceived as low-hanging fruits when we think about infections or preeclampsia or all these other things that we thought we should have a handle on in 2024. Take us now to 2016. This is when you form Black Mamas Matter Alliance. You become the executive director, right? I think 2 years later. But talk about, okay, everything comes to a head now, and clearly, as you say, hotspot. We got a major hotspot in the United States with this major problem. Take us to 2016 and you setting up the new organization.
Yeah, I actually have to take a few steps back from
Just
2016
go ahead.
because, and the reason why I say that is because really the formation of Black Mamas Matter Alliance really is rooted in just the organizing prowess, I will say, of Black women and how they can come together.
Hmm.
Reason why I say I want to take a few steps back is because it was really in 2015, some of my colleagues with the Center for Reproductive Rights, and then also in partnership with Sister Song, actually came together around 24. Actually, it was 2014 that they came together
Okay.
and they did a project that actually stemmed from the Amnesty International 2010 report
Okay.
around that sounded the alarm around the rising maternal mortality rates in the US. And they wanted to dig a little bit deeper. And what they did was they had a few focus groups, particularly here in Atlanta, Georgia, and Mississippi. And it just so happened that I was still connected with Sister Song, one of their organizers at the time, because I still kept my while even though I was uh working at CDC, I still did a lot of volunteer work with a lot of the community-based organizations. So we would always engage in information exchange, being
Hmm.
at meetings and that stuff. And so say all that to say that I supported some of the efforts with their focus groups here in Atlanta, where they were talking with Black and Latino women just around what are your experiences around pregnancy, navigating the healthcare system. And those focus groups illuminated some very interesting experiences that later we were able to state in a report called Reproductive Injustice that they put out by 2014 that really highlighted some very disturbing human rights atrocities. And to think that in a country where we spend so much money in healthcare services that unfortunately, these acts of racism, these acts of mistreatment, and simply not even listening to people during not just their pregnancy experience, but then also during labor and delivery, and the levels of pain that people experience, or not even being given the proper set of medication in the postpartum period. A lot of that was very illuminating, surprising, and sometimes even shocking, especially considering some of the stories that we heard of Black women in particular who were threatened with being criminalized, right? Because of a number of issues, just again, interacting with the healthcare system. And so it was through those efforts from CRR and Sister Song that after they put out the report, they um, did some testimony at the UN, but wanted to keep this momentum going. They then um, implemented a convening in 2015. And that was really kind of I would say, the initial birthing process, if you will, of at that time it was the Black Mamas Matter Project.
Okay.
And it was several of us that were convened at the Mother House here in Atlanta, Georgia. And we talked about a number of issues around that we believed might impact like what we are seeing with maternal mortality and the fact that it was impacting Black women in particular at a
Mhm.
disproportionate level. And so, so much was raised, everything from lack of policies that support sexual, maternal, and reproductive health in general. Also, the lack of, again, funding support for community-based organizations and clinics at the local level. But then also, just at that time, there was like barely any kind of research literature around just even the experiences of Black women, Latino women, just BIPOC women in
Mhm.
terms of their sexual, maternal, or reproductive health experiences and what they experience during pregnancy, what even they want in
Mhm.
terms of their care needs during pregnancy and labor delivery and postpartum. And so that was raised in terms of gaps, significant gaps in the research. And then also just the need for quality of care and culturally congruent care.
Mhm.
We were fortunate in 2015 to have in the space, we had midwives, we had doulas, and this was at the time where the term doula wasn't that sexy. So we had midwives, doulas, we had a handful of OBGYNs who were very courageous, I will say,
Mhm.
at that time. We also had abortion providers in the space. We had yeah, public health professionals and other community organizers and health advocates in the space, all and including, interestingly enough, artists. And
Mhm.
so all of us were talking about these issues and were able to pull out these bucket areas of needing better policy, needing more research, needing more to happen around quality care, but even more so holistic and integrated care. And then this other bucket area around shifting culture, but in particular, um, there needing to be more work done around dismantling these very negative, racist narratives around Black women, girls, and femmes and Black motherhood, because again, these narratives and stereotypes, we saw threads of that in hearing from the folks that we spoke to during those focus groups from the original report about how they're entering a hospital or and they're being talked to in a way that it's like, what kind of assumption does this nurse or does this intake person have of me just based upon them looking at me like they're talking to me, making all kind of assumptions, and so I raise that as an example to say, um, we really felt and believed even then that we had to do something about dismantling these negative narratives
Mhm.
because it does genuinely translate into how people not just treat us, but even the how people value our lives, or even care to value our lives in the healthcare system. So all of that work, especially in 2015, translated into the Black Mamas Matter toolkit
Okay.
that we released out. And then from there in 2016, once from the success of the toolkit, honestly, because so many people in the field was using it and reading it, Center for Reproductive Rights and Sister Song came together again during our second convening to say, okay, it's clear that more needs to be done here. And 2016 at the time was a very interesting time period in our country because we were headed towards an important election. And so and I'm raising that because that was part of the momentum
Mhm.
behind why we felt like there needed to be an intentional entity that was formed to be a national platform on what we coined as Black maternal health.
Mhm.
And myself, along with four other individuals, we came together um, late October of 2016, right before the election, the 2016 election, to then um, have a strategic retreat. We talked about all the things from the previous convenings, and where we settled on was to call this initiative the Black Mamas Matter Alliance. And we settled on alliance because we felt like we didn't want to call it a coalition. Coalitions kind of gives a signal of you're working on one issue or a few issues, and
Mm,
then it kind of wraps up. We understood that the issues around maternal mortality is so complex, and to actually work towards not just um, significantly reducing the disparities and inequities that drives maternal mortality and even severe maternal morbidity,
hmm.
but the actual work of ending maternal mortality is actually a global fight,
Yeah.
especially given that we knew that um, Black women, even across the globe, still make up the highest rates of in maternal mortality. So we knew that this work is, again, much more larger than us. And then most importantly, that there have been Black women-led organizations that have been doing this work long before we came to the scene. And so it was important for us to formulate ourselves as an alliance
Mm,
to recognize and give reverence to the Black women organizers and organizations that already exist. Because what was big for us was understanding that Black women's scholarship, Black women's leadership, Black women's labor and care work in this space has always been unfortunately devalued. And what's so ironic about that, especially in this country, is that it was really the Black woman's body that was the birthplace of gynecology, right? And so not only that, but then also when you
yep.
think about biomedical research and the HeLa cells that came from a Black woman's
Yep.
cervical cells, right?
Yep.
So it's like everybody's benefiting from the bodies of Black
Hmm.
women,
Hmm.
right? And the scientific and medical advancements that came from that, but we are not being valued in
Hmm.
terms of how we are treated in the healthcare system. Our care work around midwifery has
Yep.
been politically pulled away and dismantled over 100 years, right? And then thinking about research, so many Black women have tried to do research in this area but can never get funding. And so, again, this is all of these things
Yep.
went into why we said we're going to call ourselves the Black Mamas Matter Alliance. We're going to be a national platform to advance Black maternal health rights and justice. And we're going to be unapologetic about, as we're uplifting the importance of maternal and infant health equity, it's non-negotiable that it has to be rooted in reproductive justice.
Hmm. Hmm.
Then the
Let's.
election happened. And yeah, so I'll stop there.
No, no, I'm enjoying this, and I really want to drill down on several of these topics that you're mentioning, and one, I mean, I know you're gonna have to go back a couple of years on this one because I'm gonna leap forward, but I think I'm just interested in it personally, but because you were mentioning the lack of just general research literature, and it was just last year in March, 2023 in BMC Public Health that you put out this paper, Maternal Health Equity in Georgia, sort of looking at, how we define the research priorities. And I know Georgia, if we look down we have major problems in terms of pregnancy-related mortality. Along the themes we were talking about, and specifically in this paper, which you put together with thought leaders from Morehouse and Emory and Women's Health, Johnson and Johnson, and other important thought leaders here. You're pointing out, look. we have this definition of health equity, but we don't really have any clear definition of what maternal health equity means and what our core research priorities should be. Can you say a couple words about this paper and then sort of what you determine the most important research priorities to be based on this interesting Delphi method, which I don't understand too much about, but if you want to walk into that as well, that'd be cool.
Yeah, so that initiative actually came out of Center for Maternal Health Equity under the leadership of Dr. Natalie Hernandez
Okay.
at Morehouse School of Medicine. And from that project that we did, I was one of many stakeholders that were part of that initiative. And she had us do the Delphi method where and I am not a a researcher
Me either.
in the sense of the levels that Dr. Hernandez is, because she does that and she does it well. But what I can briefly mention about the Delphi method is that definitely it involves like setting priorities and ranking these
Hmm.
sets of priority areas that a group of folks are wanting to focus on. And so we did a number of polling sessions, if you will, to like really figure out what were the key priority areas that we felt like was possible to achieve with the diversity of stakeholders that were at the table for
Hmm.
that particular initiative. And that initiative at the time was, I think it was we were calling ourselves the Georgia Maternal Health Research
Yeah.
task force, something to that effect. And pardon me, because at this point I'm a part of a number of coalitions
Sure.
and task force, so trying to keep up with names
No,
of
it's
everything is sometimes challenging. But nevertheless, a lot of great people were part of that initiative. And what was important around going about that task was understanding what our levers of influence
mhm.
were and ensuring that there was a clear understanding of what resources, right, we did have at our disposal, even though at the time there wasn't a lot of strong political will to support genuine maternal health equity
Got it.
in our state of Georgia. And so that kind of had us all to kind of force ourselves to hone in on particular priority areas. So that's where a lot of that came from. And so with that being said, especially folks like myself that was representing BMMA and some of the other, I would say, social justice focused stakeholders that were at the table for that initiative. Again, for us, we were non-negotiable around um, uh, health equity and social justice and human rights focused approaches
Mhm.
to how this work is done, especially in our state in Georgia. And so that did ruffle some feathers among the task force. And so that all of that drove the work that went into trying to just define
Yep.
maternal health equity for how we were doing the work so that it was understood that at least for all of these multidisciplinary stakeholders that were at the table at the time, we can have these sets of agreements and understanding around some common definitions so that how an academic institute is talking about equity, isn't that far off from how a health department is talking about equity versus how a social justice organization is talking about equity. And
Mhm.
so that in and of itself and going through that process was definitely revealing, eye-opening, and very important
Yeah.
in terms of just understanding what it's going to take to really drive change from a systemic perspective, especially when you have multiple stakeholders, decision makers at the table. Yeah.
Hmm. Hmm. Yeah, and again, I just wanted to point that out again from the perspective of, well, you being at the table with, all these important thought leaders and defining, what this even means in terms of maternal health equity, but ultimately setting the sort of the research and priorities behind all this. So that's extremely important. You mentioned midwifery and doula care before, and I thought this would be an interesting time because I know this is one of the core areas of the organization, and it's interesting. I just sort of went and looked at some of the data before we did the show, and if you have something like 14,000 midwives that are in practice in the United States, something about 9,000 doulas, but 90% of the midwives are white. 94% of the doulas are white. And, we have some interesting, let's just say, dynamics with regard to how, all these folks are certified now. And I think my typical association with midwifery is that, in any movie where, there's an elderly woman that says, "Hey, I birthed 6,526 kids, and they were all healthy," and that story. What's the current status with? I mean, clearly there's a story here that I'd like you to go into in terms of the inequities here, but walk us through what's going on at the Alliance per midwifery, per doula care, and a little bit of sort of this dynamic. I think this is an important part of the community is sort of bringing all sorts of components of this together.
Yes, absolutely. So first and foremost, I will say at the basic level, there's still not enough midwives, and there's not enough doulas, there's not enough in general maternity care providers. That's inclusive of OBGYNs, labor and delivery nurses, and even maternal fetal medicine specialists. And the list goes on in terms of the all the types of maternity and reproductive health care providers, to be quite
Right.
honest with you, in the United States. So when you're already starting kind of bad,
Yeah.
then when you're looking at the landscape of who makes up the folks that are in these different maternity care professions, like midwives, like doulas, like nurses, yes, the vast majority of folks are white. And a lot of that is because of the fact that our country and our healthcare system has decided, at least over the last 100 years, to prioritize certifications, and also quote unquote medical rigor in how it determines and provide licensure
Mm,
to folks to actually practice. The reason why I'm talking from this perspective, because again, here goes another ironic situation, is that it's interesting that during the institution of slavery in the United States, part of the main reasons why at some point during the transatlantic slave trade that the US was interested in actually, you know, unfortunately, capturing midwives
mm,
in particular, or women that are skilled in this area of birth work or birthing process from a lot of the what is now West African countries, was to be able to bring them over to the Americas and help with the process of reproducing, quote unquote, more slaves, right?
mm,
And the actual process of, yes, what we call midwifery care now, again, comes from and stems from these traditional birthing attendants, is what we would call them now, and their practices and their ways of taking care of women during the pregnancy and birthing periods. So much so, they were trusted for such a long time, so much so that those midwives that uh, at the time, by the time you got to like the 1800s, were called traditional midwives. They were trusted even by their masters, if you will, to also support the wives of the masters in the birthing process. So they were the ones that were doing a lot of the what we call pregnancy work of
Hmm.
today. It was really in the at the turn of the century. This was like late 1800s, early 1900s, where you did have a rise in the medical professions, and definitely policies that arose, like the Shepherd-Townsend Act, that really stepped in to put a very negative view on midwifery practice. You started to see a lot of cases, especially in the Northeast, um, which was interesting. I was like, man, they went from burning witches during the Salem to calling midwives witches by the time
Hmm.
you got to the 1900s. And that really is what propelled a lot of this, if you will, domino effect around um, stripping away, quote unquote, traditional midwives from being able to practice
Mm.
to it becoming like medicalized. Pregnancy became medicalized. Pregnancy became something that, or labor and delivery rather, was something that got trans transitioned into the hospital,
Yeah.
and something that a physician needed to supervise. And then throughout time, is when you started to get what is now nursing, and then eventually certification for midwifery, right? And so all of that, and our the history of our country, in everything, racism plays a significant role. All of these things is what contributed rather to why in our present day we don't have a lot of people of color in the field of midwifery and doula services.
Mm.
I will say that to say things more hopeful, in a optimistic tone, I will say that this is part of the reasons why we at Beam and May, when we formatted ourselves, that we were non-negotiable about addressing these negative stereotypes and narratives, because it was through us doing, or rather founding, Black Maternal Health Week and amplifying and like removing this weird veil
Mm.
around midwifery practice, because folks would be like, oh, these are old wives' tales, or people will whisper like, oh, they're going to promote home births, like that type of,
Right, right.
until those things were like, again, removing those weird myths, right? And being able to amplify the fact that actually midwifery care and doula care, and just continuity of care throughout the pregnancy and labor delivery, along with, if you need it, an OBGYN, is essential. And
Right.
that there are other um, avenues of
Hmm.
birthing outside of the hospital that actually
Right.
is helpful for better birth outcomes, whether that's at a birth center, or at a community-based clinic that's set up as a birth center or connected to a birthing hospital. And
Mm.
so I will say now, there is so much opportunity now to really make a significant dent to the stats that you mentioned earlier, to increase the number of Black and brown midwives and doulas. It's happening now, but there's a lot of work, and we still got a lot of strides to go. Yeah.
Got it. Got it. Um, Along those lines, I know you have organized something called the Black Maternal Health Incubator. There is I guess the pilot cohort, which is specifically focused on perinatal care, and I assume this is going to be topics like breastfeeding, nutrition, I guess everything in the after, so the reproductive care following birth. Could you take us into a little bit of what went into forming the incubator, sort of what the status of it is now, if there's the initial cohort's been chosen, and a little bit of what's happening there, and sort of where, because I know that you're involving various different community organizations in this as well. Please take us into that.
Absolutely. So, we were fortunate to receive some seed funding from Pritzker Children's Initiative back in 2021 to
Hmm.
actually just plan something,
Right.
because we really wanted to do some work around, yes, workforce development and what that would look like in this arena of Black maternal health. So we had to more so focus on building our own capacity as an organization at BMMA to bring on the necessary staff. And then what we did was we were able to finally implement our Black maternal health incubator hub in the summer of 2023 is when we opened up applications. And again, because of the funding that we had to be modest with the amount of folks that we could support in our incubator hub. So essentially our pilot cohort had 10 spots for us to have up to 10 community-based organizations that were in particularly Black led. We wanted to really hone in here because we really wanted to focus on capacity building
Yeah.
and hone in on entities that were Black led entities that were already doing some level of perinatal work, whether that was lactation um, work, or if they did doula work, or if they did a combination, or if they did a number of what we call perinatal health programs
Hmm.
at the local level. And the area that we hone in on in terms of quality improvement was more so to focus on inclusive perinatal care.
Hmm.
We landed there actually from doing a number of surveys and from uh, work that we had did coming off of our Merck for Mothers funded Safer Childbirth Cities initiative,
Yep.
where again, even during that process, we really spoke with a lot of community-based organizations to really understand what their interests were around training and where they wanted to develop. And what bubbled to the top in all of these processes where we were surveying the Black perinatal workforce, a lot of people just had so much interest around inclusive care. So inclusivity spanning everything from how do we provide better services, culturally congruent services to people who are LGBTQ, to folks who are have varying abilities, so even disability services. How can we incorporate that in what we're doing? And then also how can we better understand and get better rooted in these principles around birth justice?
Hmm.
And so all of that informed what we were offering in terms of our trainings in our incubator hub pilot cohort. So we were able to do that we were able to actually implement it in the fall of 2023 with 9 CBOs across the nation that took a series of courses with us. We also had I think we had about 4 or 5 trainers that were part of our cohort. that led these series of learnings and trainings. And then our cohort participants were charged with creating a capstone project and demonstrating how that they were going to plan to implement their learnings into the work that they did.
Hmm.
And so it was earlier this year, 2024. This was in early February where we brought all of our cohort participants together for a convening. They presented on their plans of action of how they're going to implement their learnings. And we set the convenings up in a way that allowed for people to get real-time feedback, for people to exchange information and knowledge on how they were implementing the work that they were doing. And we've also set up a way for all of these folks to stay in touch. We do plan on doing like a 6 to 8 month follow-up evaluation with all of our cohort participants just to see where how far they've gotten. And what I'm talking about is like the typical cycle of quality improvement in healthcare, but for us, we're doing that, but at this community-based level and incorporating these culturally congruent components to it.
Hmm.
So, the other significant part about the pilot cohort was that we were also able to offer mini grants to
Okay.
each pilot cohort, which is very, very important to us because we understand the mini grants were about $10,000 each. And while it was a modest mini grant, but nevertheless, it was still an important investment and resource so that
Right.
these organizations had more of an incentive to implement the learnings from the Incubator Hub. So those are the things that we were able to accomplish.
Awesome. Awesome. And speaking about grants, and you probably know a couple months ago, I had Daniel Hallstrom on the show, president of the GE Healthcare Foundation, which was just rolling out at the time, and you are one of their inaugural grantees, and they had great things to say about you and the organization. Could you say whatever you can say? I mean, I don't know if there's confidential stuff, whatever, but could you talk a little bit about specifically the GE healthcare program that your grant is going to be covering, if there's anything that you want to highlight that you're allowed to highlight at this stage. And yeah, I mean, obviously just being a grantee of one of the largest sort of health tech companies in the world is very important. So take us down that path if you would.
Yes, so we are very so in deep gratitude to GE Healthcare Foundation for even taking the time to assess what it means to look for grantees that are genuinely implementing maternal health equity work.
Mhm.
And so us being one of their first set of grantees, we have deep gratitude to that. The funding that they were able to provide went towards us being able to implement um, our training institute and having 4 facilitators as part of our Black Maternal Health Conference and Training Institute that we just put on this past September 12th through 14th. It was a huge success. We had, and our training institute in particular is like, it happens the day before our 2 day conference. Typically, we attract anywhere between 450 to 500 people to our conferences. This year, with the the intentional incorporation of our training institute that was supported by GE Healthcare Foundation, um, we were able to have like 4 full day long workshops. And so these were in-person, hands-on training workshops, again, for the perinatal workforce. Um, and what was so amazing about our training institute was that we had well over 100 280 attendees
Mm,
to the Training Institute, which was is huge for us because this was an additional cost
okay.
for attendees separate from our conference. And so the fact that that many people were significantly interested in topics like um, culturally congruent focus groups, and I think I'm messing up the title of that workshop, but it was definitely heavy in, yeah, research and evaluation, but a particular methodology approach around focus groups to we had a midwife-led workshop where she talks about abortion and post-abortion care because
Mm,
people really forget about that time period of pregnancy because there's a lot of significant care that happens in that time period. And so that the midwife that we had lead that session, she was able to do that. We had a whole session on cardiovascular health
okay.
um, and the intersection of cardiovascular health and perinatal health care, but again, from a community-based perspective and the ways in which doulas and lactation consultants can lean in into that work. And the last workshop was on yes, inclusive perinatal care for doulas.
Hmm.
And again, these topics were topics that kind of came out of further arisen out of our pilot cohort of the Incubator Hub because we were only able to have a small amount of people be a part of that Incubator Hub. And so we felt like, okay, we want to be sure to provide these topics and offerings to a larger audience. And so that's where the GE Healthcare Foundation funding support lend a helping hand. And so, and right now, we are currently planning our fall perinatal health learning series, again, being supported by the GE Healthcare Foundation.
Nice.
And this learning series is going to be offered virtually. So we are also hoping to be able to capture a more larger geographical audience with these series that we're implementing in November. And we have a number of topics that have arisen, and I think it already has been posted to our social media account. So the registration is currently open. So we are very grateful to GE Healthcare Foundation because they understood our perspective and our approach into the work that we do, and in particular, our commitment to be able to pour into increasing the number of Black and brown uh, perinatal workforce because we
Hmm.
we need more. We need more
Hmm.
maternity care providers. Yeah.
Yeah, no, it's obviously an awesome partner to have, and as I said, they love you. So I know I'm excited for you that you know they have those resources as a grantee, and that's just an awesome piece of the story. Um, Angela, while we have you, I mean, I know we've talked everything from prenatal to birthing to perinatal care. I was wondering if you could just say a couple words because I know. Actually, this is quite recently. I think this was a couple weeks ago. This paper in JAMA came out that you were involved in terms of preferred sources of contraception and the survey that you did. Again, with another really long laundry list of thought leaders throughout the United States. Can you say a couple words about just in general what's happening in regard to contraception in 2024 in the U.S.? I mean, I was a child of the late 60s, early 70s that came of age in the 80s. And of course, we had to balance pregnancy and this HIV thing that was coming up to be a problem at the time. What should we know about contraception in 2024? And specifically, are there things that BMMA is focusing on in this regard?
Yeah, great question. I will say that still. What we should know is that the vast majority of people, all of us, even folks in the healthcare sector and public health sector, we don't know enough when it comes to not only what is readily available as contraception, but then also what people prefer and what works best for folks, not only in the various stages of their life, but also geographically, and also depending even when it comes to people's weight. There's still more research needing to be done around that, around
Mm,
the effectiveness of certain types of contraception and people at differing weight. And then also who's allowed to provide contraception access,
mm,
especially in the wake of abortion bans in a lot of our southern states.
mhm,
Um, I raised that up in particular because, in the state of Louisiana right now, a contraception, or I will say, maybe it shouldn't be classified as a contraception, but a perfectly uh, effective and medically sound medication for medical abortion is being considered as a controlled substance.
yeah,
you know, Again, this goes back to like misinformation and what people are choosing to believe as scientifically sound information. And so that is the state of affairs that we're currently in,
mm,
unfortunately. And then when you think about the full offerings of contraception and even family planning, depending on where you are located in the US, does depends on or has an impact on what types of contraception is even available for you to access.
mm,
So I'm saying all of that to say that, again, this is still one of those areas where more work, more research,
sure.
and more policy support is needed in this area. And most especially when it comes to how contraception is even offered during like reproductive health visits, and ensuring that it's offered in a way that is patient-centered
Mm,
and not from the perspective of coercion,
right.
because that is a big thing for the experiences of most especially low income Black people and Hispanic and Latinx people, where we have had an unfortunate history of coercion being pushed towards certain types of contraception to quote unquote get us to stop having too many babies.
Mm,
And so knowing that that is a very negative approach to contraception care. And so being able to come at this work where, again, we're trying to uplift and center the patient's perspective and what they need and what they're wanting at that particular time around their contraception is very important work to be engaged in. And I really do give thanks to Dr. Anu Gomez, who led this effort and went through a significant process to ensure that multiple voices were at the table in how this research project was implemented. In terms of BMMA, our priorities, most especially in this area of contraception access, really sits in this larger policy agenda that we have, which is the our Black Mamas Matter in
mhm,
Policy and Practice policy agenda, where we talk about the need for more expansive approaches to sexual, maternal, and reproductive health. Contraception access is in there, but is definitely one point in a larger slew of programs, services, and support and investment that really is needed across the full scope of sexual, maternal, reproductive health for everyone.
Hmm.
Because we really do believe that, I know I talk a lot about Black women, Black women's leadership, and Black women's care work, and our health outcomes. But the key thing to understand is that when we center the people that are most vulnerable in a lot of these issue areas, and we actually center the solutions that supports them the most, which
Hmm.
is equity work, that actually has a significant positive impact for everyone.
Right.
So with all of that being said, I know we started talking about contraception, but I have to end it. I have to land here that with all that being said, a lot of our policy areas around everything from contraception access to general sexual, maternal, reproductive health care, if we follow these approaches and these solutions, it will have a significantly um, positive impact for everyone,
Right.
men included,
Yep.
significantly men included in that.
Right.
And so, yeah, because it's important to note that we do need to improve things when it comes to our maternal and reproductive health care in the United States, because it's not good for white women either. And so there needs to be a significant turnover into the positive of
Hmm.
everything in this arena. So yeah.
Excellent. Excellent. Yeah. And again, I appreciate, I know I took you a little bit out there, but I did, the fact that I saw the paper sitting there from a couple weeks ago and that you're involved in this important piece of the of that puzzle as well. I'm glad that you took a couple minutes to walk us through that as well. So that's important. Um, uh, what else is going on? I mean, obviously, I've we'll be linking to BMMA in the bio of the show, and clearly you have a lot more going on than just what we talked about. I know Black Maternal Health I guess we missed, well, it's coming up in April again, but we got a little bit of time. What else should we know about between now and next April is happening? Other events, other initiatives that are public facing, anything you want to talk about while we have you today, please take the floor.
Absolutely. Thank you for that. Like many other nonprofits in this country, we too are definitely in need of support to continue this work. And most importantly, this work is going to be that much more significant and important to invest in and resource, no matter what the outcomes of
Hmm.
next week's election is. Um, there's going to be a lot of work to do regardless, because like I stated before, we are not in a good place when it comes to maternal and reproductive health in this country. And so some of the things that we're going to be leaning into at BMMA, yes, we're gearing up for Black Maternal Health Week, which is April 11th through 17th.
Hmm.
Um, and we are also, even a few months before that, we are hoping to be able to engage more specifically at the state level, along with our partners in the Alliance, to really engage state legislators and other health department decision makers to push forward some maternal health initiatives.
Hmm.
We know that more needs to be done around expanding midwifery access and having policies at the state level that supports expansion of midwifery scope of practice.
Hmm.
There's more work that needs to be done around Medicaid reimbursement around maternity care, period, because even physicians, OBGYNs are not reimbursed at a decent rate. So if they're not reimbursed at a decent rate, that means that midwives and doulas get pennies.
Right. Right.
So we need to see more investments in maternity and reproductive health care from health insurance providers. And so these are some of the big policy issue areas that we're leaning into. and trying to do more state level work around that. Also, we want to do some more community engagement work because there's more health education that needs to be done.
Mm.
We are hoping to put on our Black Maternal Health Culture Fest in 2025. And we are definitely looking for vendors and sponsors for that. And then, of course, we will bring back our Black Maternal Health Conference and Training Institute in 2026. And so we're still doing some work around that. There are a number of research projects and other policy and workforce development projects we are wanting to lean into, but those initiatives definitely needs investment. And
Mhm.
so for anybody who wants to support our work, wants to follow our work, I always tell people, please sign up for our newsletter. And they can do that by going to blackmamasmatter.org/connect. That way, not only are you keeping up with all of our initiatives and opportunities that arise, but there's so many ways to get engaged with the work that we're doing and to stay on top of the latest advancements in Black maternal health.
Outstanding, outstanding. No, you got a busy few years ahead of you, Angela, but it's exciting time. I enjoyed hearing your story and sort of the entire arc of where you've been and where you're headed, and just really rooting you on. And I look forward to, as I said, we'll be putting the link in the bio of the show, and we'll help spread the word. But really, very impressive stuff, Angela. Um, Again, for everybody that's going to be listening to this particular episode of our show across the various podcast networks, or who will be watching on our YouTube channel, again, you've been spending time with Angela Aina, co-founder and executive director, Black Mamas Matter Alliance, doing really amazing things to advance Black maternal health, rights, and justice. Angela, again, I really want to thank you for taking a decent amount of time out of your schedule to talk with us today about what you're up to. I mean, thank you everything you do, and as we like to say on our show, thanks for helping to create a better tomorrow for so many people out there via the type of work you do. Really an awesome story.
Thank you. And thank you so much for having me and allowing us to have this conversation. Thank you.
Great, great having you.